spirochetal forms that cut a streak across from 7 o'clock up to about 2 o'clock. Keep your eye on figure on the spirochetal form at 11 o'clock. Looks exactly like this, which is a ring form of Borrelia burgdorferi from our positive control where we mix spirochetes up in agar and stain it with silver. So that matches that. So you must be prepared to deal with alternate forms. Here is a spirochete stained with monoclonal antibodies from Dr. Barber's lab from the cord blood preparation of the case I just showed you. And once again, the unifying feature was toxemia of pregnancy. We have had cases where, unfortunately, oral antibiotics in pregnant patients with Lyme disease have failed to eradicate the disease, and there's been an adverse fetal outcome. The German case I've already shown you, the case of Dr. Klaus Weber. In this case, the parents wanted to sue the obstetrician because they believe the baby died due to birth trauma. And that scenario is played out an awful lot in this country too. In fact, the baby had viable spirochetes in fetal brain, and there was no evidence of birth trauma. Southampton case, we have found spirochetes in placenta despite oral antibiotics. So once again, coming back to Dr. Weber's case, that's a spirochete in fetal brain. It's got a little tadpole head on it, but that is a legitimate form of Borrelia burgdorferi. And in our case, the baby didn't die, but the mother had been treated for Lyme disease during the second trimester with high-dose oral antibiotic therapy. The baby appeared well at delivery. Spirochete in the placenta at delivery. So the spirochetes were not eradicated by high-dose oral antibiotic therapy. Now, we've covered a lot of territory. We've covered miscarriage, stillbirth, neonatal death. All of those are possible in syphilis. They're also possible in Lyme disease. The fourth line is death in early infancy. And that was an outcome that happened in about 20% of women who had syphilis in pregnancy. So it's logical, if we've had connections at levels 1, 2, and 3, to look for possible connections at level 4. What would we be looking for? We'd be looking for a baby that died within the first months of life with no antecedent clinical illness, whose autopsy showed normal histology in all organs, no inflammation. What would that category be called? Unexpected death in infancy. And some people call it sudden infant death syndrome. These are cases that come under the domain of the medical examiner. There is evidence that SIDS cases have their origin in the perinatal period. There's lots of theories about what causes SIDS, and I don't pretend to understand all the possible causes. We did request some SIDS autopsy tissues, and we went looking for spirochetes in the autopsy tissues. Once again, the definition of SIDS, a sudden and unexpected death of an infant, which a thorough post-mortem examination fails to reveal an adequate cause of death, etc., etc., etc. Infection is one of the theories that they have for possible SIDS death. Other theories, toxic theories, cardiovascular abnormalities, all of these have been documented in one case or another. But there are always categories where you still don't know. Borrelia infection, sudden infant death. I'm going to show you 2 cases from our series so far. This is culture cyst. This is the fetal brain. And you see that the spirochete has wound its way up to the focal plane, dipped around the nucleus, and then come back up into the focal plane. Frontal lobe cortex of fetal brain. Now, I always want to have peer review on these things, and I've had Dr. Paul DeRay look at this slide, and I told him that it was a brain from a dead baby, and I asked him what he thought about it, and he said, "That's our little friend, no doubt about it." Just for comparison, that's what they look like in some of the controls. Agar control mixed with spirochetes. They're not always coiled. They might have a little sperm head or a little tadpole head on it. Case number 2. Frontal lobe cortex from a SIDS baby. And so, to conclude, as the spirochetes wave goodbye to us, I think that we have an awful lot of work ahead of us to try to firm up some of these clinical observations, small sample observations, and to build on the knowledge that we have in the hope that may provide better care to our patients. Thank you very much. I think that by that time we'll have more information, but I just want to, we're not nutritionists, not nutritionists, Lyme disease physicians, we're going to have a point of view on how to manage that patient. There may be something better tools available at that time.
I'm Ed Koch. Listen to Mr. Reyes' advice. Hola, me llamo Juan Reyes y tengo 2 hijos en la escuela superior Utah. Desde que llegué a Nueva York, mi sueño ha sido que mis hijos estudien y se gradúen. No soy anticuado. Yo sé que el siglo XXI está a la vuelta de la esquina. La era de naves espaciales y computadoras que hablan. Estoy contento porque los muchachos van a la escuela y hacen sus tareas escolares. Yo sé que ellos van a ser parte del futuro y se van a graduar. Que ustedes sean parte del futuro. Gradúense. This is WKQ New York.
The next speaker is Dr. Robert Lesser, who is an associate clinical professor at Yale University. I came in contact with Dr. Lesser during a conference at Yale, and subsequently he's been very helpful. You may not know this, we've had some animals with Lyme disease, and he's made a number of connections for patients with neuro-ophthalmologic problems in humans and in animals for us. So we appreciate his efforts for the foundation, as well as the speech that you're about to see.
Good, thank you. Speaking of soporific, it's late. I apologize. I just hope I don't fall asleep through my own talk. But the good news is I'm the last barrier to the end of this, so you can have some peace. You can't hear me? Pardon me? Can you hear me now? Okay. A little bit? Better now? Okay. Can I have the first slide, please? Okay. What I actually want to review a little bit first, and can you hear me now? Okay. Thank you. Is first to go over some of the neurologic findings, which many of you are familiar with, and then not just focus on the neuro-ophthalmologic problems, but some of the eye problems that have observed, as well as review some of the cases that we've seen. And in what I think is now a classic study by Packner and Steer, in which they reviewed their patients, 38 patients with Lyme meningitis that were seen at Yale from 1976 to 1983, they found 38 patients and described the classic triad of the neurologic findings, which is here, of Bell's palsy, which could be unilateral or bilateral, meningitis, and the radiculopathy, that is a peripheral neuritis, whether it be motor or sensory. In the patients with the Bell's palsy, which there were half in this series, they were more unilateral than bilateral, and it lasted from weeks to months. And indeed, in most neurologic series now, the most common cause for bilateral facial nerve palsy is indeed Lyme disease. Differential, of course, would include sarcoid and Guillain-Barré, depending upon the location of Lyme disease. It's very important in the differential diagnosis. Of note, when treated, the Bell's palsy cleared rather quickly. In the patients that were studied before treatment was known, the duration of the Bell's palsy varied and went for, in many cases, many months. Of interest, in many cases, the Bell's palsy was preceded by a sensation of numbness or tingling or some sort of paresthesia, but that could not be objectively documented by the neurologist examining the patient. The peripheral neuritis was found in a little more than 1/3 of the patients, actually, and it really varied. And patients would often complain of either localized pain, in particular dermatome, or perhaps an extremity, part of an extremity, and it could be unilateral or bilateral. Some patients were left with focal motor weakness. And this is a diagram taken from that paper, just illustrating different courses. And you can see that it can involve either the face or the extremities or different parts of the body, and patients complaining of extreme pain and distribution of a particular nerve. Now, in addition to the, actually before I mention about third stage Lyme disease, let me just mention briefly also about the meningitis, to say that to be included in the study, one had to have evidence of cells in the spinal fluid, so-called pleocytosis. And but what's important to know is that early on in Lyme meningitis, there may not be any abnormal cells. There may be no cells in the spinal fluid. So just as in Guillain-Barré, that an early tap may not pick up those cells. What's also of interest and becoming increasing evident, where the second stage of neurologic findings, the findings of Lyme disease, which would fit into the second stage of Lyme disease, would be the ones I described previously. But there is another category of patients where their onset may be as long as a median of 5 years after the Lyme disease, the so-called third stage Lyme disease. And this was described recently also by Packner and Steer. And they had, I think it was a total of 13 or 14 patients in this particular article, and categorized them into 3 groups. One was a group of chronic fatigue patients, all of whom, interestingly, were children, some of whom had a sort of an anorexia-like nervosa picture, and basically presented, 3 of those children, 3 of the 4 children in this group, presented only with fatigue and had nothing that had suggested Lyme disease previously. There are also others that presented with unique clinical neurologic pictures, including dementia, sort of generalized neurologic findings, mood changes, mood swings, encephalitic-type pictures. And then there are others with more specific chronic cranial nerve paresis, transverse myelitis. So, and I think that it's become increasingly evident that there are patients with dementia that are presenting with Lyme disease. But I would like to take issue with what the statement that the gentleman made earlier this afternoon. To my knowledge, there is no association between Lyme disease and multiple sclerosis. Although the magnetic resonance imaging picture can appear similar, there's no evidence to support that people who develop Lyme disease are at greater risk of developing multiple sclerosis. They are at risk for developing, particularly untreated, for developing another neurologic picture which in some ways could mimic multiple sclerosis. One other point in reference to the meningitis is that, as is characterized by Lyme meningitis, predominantly the patients had severe headache. It can be diffuse, it can be occipital or frontal, as opposed to the meningitis that's described as Banworth syndrome, which is the European tick-borne meningoencephalitis, in which the meningitis is actually quite uncommon, or in which the headache is quite uncommon. Now let me go through some eye findings. really how I got involved and interested in this. And when you go back and look at Alan Steer's original papers, it's of interest to note that, highlighted best here, that 11% of his patients were described as having conjunctivitis, or red eyes. These observations were made by non-ophthalmologists, and it's conceivable that if one had studied those red eyes in a more detailed manner, that they might not, some of them might have shown evidence of corneal involvement or some sort of uveitis. Of note, some patients have photophobia, and in addition, as you can see on the last one here, there are a certain percentage of patients, small percentage, that have periorbital edema. So there are some perhaps infrequent, but still evident signs of eye disease early on in the disease. Now, what's most dramatic and of interest is that there is a case that's been reported by Alan Steer and Dr. Duray from Westchester, a patient who presented after having a case of Lyme disease, which was diagnosed and treated, presented to the ophthalmologist with a red eye. It turned out the patient had iritis, that is, inflammation within the eye, and was treated initially with topical steroids. Subsequently, the inflammatory response increased in spite of treatment, and there was posterior uveitis, and it determined that it was probably endophthalmitis. The patient was then treated with systemic and subconjunctival antibiotics, but the eye progressively worsened and came eventually to vitrectomy, where the vitreous specimen was aspirated, but unfortunately the eye was lost. Subsequently, the vitreous block was stained, and spirochetes were identified in the vitreous block. And so, to my knowledge, this is the first case of documented unilateral blindness occurring from Lyme disease. Now, there are animal studies which I won't go into in any detail except to say that it's been documented that spirochetes can, in hamsters, involve the eye quite frequently and may potentially lay dormant there for a long time. In one study, they found that about 50% of the animals had evidence of spirochetes within the eye. Now, I'd like to, in the remaining time, just review with you some of the cases that we have had. And I'm going to show you two cases that represent changes within the cornea. This first one was in a patient, in an adult patient who noticed a red eye, and then subsequently was observed by the ophthalmologist, had infiltrates within the cornea. And you can see how they appeared in February 1987. And almost a year later had not changed. They had not caused any symptoms to the patient and had not caused any decreased vision. They were not treated and continued to be observed. There's a slide. Is that not going down or something? The second cornea patient. And you perhaps just take it out and put it into another. I would like to show that if I could, because basically what I wanted to show you, and perhaps I'll still be able to get a chance, is that the corneal changes in the second patient started off initially in a very similar manner, but then evolved over a period of time so that there were vessels that grew down into the cornea in a pattern consistent with what's called interstitial keratitis, which is the same type of corneal change that one would see in syphilis. This patient was treated twice with courses for better than none. These are the beginning pictures here, and you can see that the infiltrates became more patchy and involved there, and the reddish material there you see actually represent the blood vessels, the neovascularization within the cornea, which is classic for Lyme. And this patient was treated, and the top one you see is the right eye, and the vessels then did regress. And interestingly, in the left eye, these stromal patchy opacities, sort of fluffy opacities, decreased, and eventually the patient was left just with some infiltrate on the posterior portion of the cornea decimated membrane.
Yes, there is a penalty for early withdrawal.
Now, I'd like then to
Speaking
review
of,
with you also
making
3 cases
appearances,
that
I
we've
would like
had
to personally
with
thank all of the people
neuro-ophthalmologic
at
findings.
David Leonard Associates and the Crest Hollow Country Club,
And the
as well as
first
the
is also a
troop
boy
from our
this
listening
is a boy
audience who
from-
came out last night. We
boy
had a
from
seminar in
Danbury.
Woodbury, as you may have heard. I was talking about it for a week.
In late 1987, late spring 1987, had a flu-like syndrome and woke up with vomiting, and presented to his ophthalmologist with a diagnosis of Lyme disease being made, and with the patient being treated with penicillin. When presenting to his ophthalmologist, his vision was 20/20 in both eyes, and the dramatic finding was evidence of bilateral papilledema, which was then documented with a spinal tap. You can see disc swelling right here on the slide. The patient was then brought to Yale and treated with IV penicillin, treatment regimen, and within a week later, the discs were flat, the pressure was down, and the patient fortunately continued to do quite well. Now, the second patient is a much more complicated history, and I'll try to be very brief with this, but illustrates a number of points, and I think it represents a patient who had involvement of both second and third stage Lyme disease. And this gentleman had been vacationing in Nantucket for almost 20 years and recalled this episode of flu-like syndrome in August of 1982. In September 1982, he noticed horizontal diplopia and had a left 6 nerve palsy. By March 1983, he had developed some other findings, paresthesias and numbness in the right thumb and index finger and tongue on the left side. Now, he was worked up extensively. This is just actually showing he's being asked to look, AV duct to look laterally. He's not able to do that at that point. He could not get his eye out any further than that. Now, this is the history that's particularly interesting. As he went around to 2 major medical centers and no diagnosis was made, his daughter came down with Lyme disease and it was diagnosed by their physicians in Nantucket. Her father then asked perhaps if he could have a titer drawn on him. And as I'm sure many of you have stories that are similar in terms of prolonged tail, similar to the presentation we heard earlier today, the blood test was drawn, but the results were never sent to the physician, and the patient assumed that the test was negative. The next spring, he found out that the test was positive. He then went on to progressively have more cranial nerve involvement. And his tongue numbness became bilateral. He developed bilateral 7th nerve palsy. And this is actually somewhat out of sequence here now, but you can see he went to other centers besides that. When we saw him at Yale, at which time the diagnosis was made, there was his vision at that point was 20/20 in both eyes. He still had evidence of now bilateral 6th nerve palsy, as well as the bilateral 7th nerve palsy. He did have more exposure keratopathy on the left eye, although it wasn't interfering significantly with his vision then. He came to Yale basically for different treatment regimens, and he's had multiple courses, both with steroids, with penicillin, Rocephin, and Cytoxan, but unfortunately his course has continued to progress down. By June 1986, his vision has fallen to 20/50 in the left eye, secondary to the exposure problems of his cornea drying out, which is one of the common ophthalmologic problems that one can see in a patient with a 7th nerve weakness. In January 1987, he noticed that his vision in his right eye was getting worse. And at that point, in May 1987, his vision had fallen to 20/30 in the right eye and 2400 in the left. By this time, he had actually developed some small cataracts, so that part of the reason for the further decrease in vision in the left eye was related more to the cataracts than to the exposure keratopathy. But of significance, he had an afferent pupillary defect in the right eye, and for the non-neurologist, non-ophthalmologist, that is a sign, there's a pupillary sign of optic nerve disease. And basically, he developed a visual field defect in the right eye and developed some disc pallor in the right eye.
Yes.
And by June of this year, his vision had fallen then to 2200 from 22.
Can I just ask you one more question?
You can in just 1 second.
You can see some pallor of his optic nerve on the right side here.
Perfectly happy to answer more of your questions. Meanwhile,
You
all
see
of
his
you
visual
should
field. And basically what you're seeing here is
and it is fascinating.
the outlined area represents the areas that he can see, and all of the other areas that are blank are the areas he could no longer see. And this field evolved really over a period of about 3 weeks. So that he represents a patient who's had multiple cranial nerve palsies, from cranial nerve 7, which is the most common, to 6, and involving also cranial nerve 2, and represents a rare patient with optic nerve involvement. The last patient is actually from Westchester, and he is a 25-year-old man who presented to his ophthalmologist in September of last year with blurred vision in his right eye. And he also noticed a rash in July of that year and basically made the diagnosis of Lyme disease by himself, in no small part probably due to the effort of the New York State Health Department and the Westchester County Health Department, and I want to compliment them, and I think it would be wonderful if other state health departments or other health departments could do something as dramatic. So he saw the picture, he made the diagnosis, went to his physician, and got treated. Told the physician what to treat him with. In September '87, his vision fell to 20/60, and he had a visual field sort of small central scotoma, and he had basically optic neuritis in the right eye. And with treatment, his vision improved by October 1st, and he was back to 20/20, and he was left with no evidence of a visual field defect, but slight impairment of color vision in his right eye. So these 3 last cases represent the spectrum of neurologic findings, of neuro-ophthalmologic findings, from meningitis with papilledema and the findings of elevated intracranial pressure, to multiple cranial nerve palsies, the last patient with optic neuritis. And in addition, the other patients presented both with corneal findings which persisted on a long-term basis. So I think the purpose of my talk is hopefully to highlight that there is eye involvement, and I think that it needs to be focused on. Thank you. Yes. Well, the only patients that I think I would expect to see with corneal ulcer are probably more related to the exposure keratopathy. The cases that we've seen with corneal changes and the other cases that have been reported with corneal changes, there have been none that have been evidence of a primary corneal ulcer from Lyme disease.
Just about 19 minutes after the hour of 6. Lisa, you had a second question about that?
Yeah. At least in humans, I'm not aware of it at all. And in animals that I've been only peripherally involved with. Yeah. It certainly would be possible, and I think if it's bilateral, if you can demonstrate some evidence of seventh nerve weakness, that would be more likely that there would be secondary ulcers rather than primary infections of the spirochete producing a corneal ulcer, based on the clinical experience. Yes. Yeah.
Fully covered at work with pension, profit sharing, IRA, retirement, medical, disability, and all that stuff? Good. Any children?
Well, I think that that's an important observation. One of the problems is that floaters are very common and a very non-specific type of finding. The thing to do is an ophthalmologist needs to see those patients to see if there's any evidence of uveitis at that point. I think that's really the important observation. Well, that it may be that there's that there is a low-grade uveitis, or it may be that it's just coincidental and really of no significance. I want to stress to you that floaters are a very common complaint, and one has to be careful in over-interpreting.
But what struck me was how it tracked their other symptoms and how the treatment affected them.
Well, there may very well be a low-grade inflammatory involvement, just as the first patient I showed you with the corneal findings was asymptomatic. And he actually was picked up initially because he went in for a contact lens fitting. And the ophthalmologist noted this. Well, I mean, the issue, of course, is of course trying to rigidly define what are acceptable eye symptoms or signs and what are non-specific, and that's what makes this extremely difficult. But I think that what needs to be done is, in an ideal world, is to prospectively study a series of patients with Lyme disease, try to isolate those who have red eyes in particular, and look at those and be able to study that. But I think that and I've spoken with people who had Lyme disease. It's quite common, and they'll say, "Oh, yes, I had a red eye, but really never thought much about it."
Quite a bit of it.
Right. Yes.
Is there any recommended treatment for the photophobia?
No. Again, this is assuming. I think that photophobia can be a non-specific ophthalmologic sign in the sense that it can be a sign of inflammation within the eye, but it can also be a central nervous system finding, and that if people have inflammatory disease within the central nervous system, you can have photophobia as a sign also. The simple treatments are basically, once you've excluded inflammatory disease within the eye, putting filters, like sunglasses or some sort of filter in front of the eye. Thank you.
Okay, that concludes our program for the day. The other thing we want you to know is that there's a get-together, reception, there's no liquor here, in the back of the room, and we encourage you to make phone calls with each other. If you have people with vets with problems or patients with problems, we encourage vets to get together, the doctors to get together, whatever you can if you'd like to start working on some sort of research project. And I'll be bringing a tape machine down, and I'll be seeing if I can get some doctors together to take a look at the pediatric cases. Thank you. Early is a volunteer for the Speakers Bureau at the Gay Men's Health Crisis Center. She's an assistant professor of clinical nursing, director of graduate perinatal program at Columbia University School of Nursing. She's a consultant in ethics and research to the nursing department at St. Luke's Roosevelt Hospital Center, working with an interdisciplinary staff on AIDS. She's interested in AIDS based on work done in her ethics and with nursing, with the medical students and personal involvement with friends. She has a BS in nursing, an MSN from Yale, and a PhD student right now in social science and public health. Kathleen? Thank you. Can you hear me? Is this working okay for the back? Okay. What I was asked to talk about, I must confess not knowing much about Lyme's disease except for what I've read in the press, but what I was asked to talk about, or actually what GMHC was asked to send somebody to talk about, was the analogy in terms of the public response, the governmental response to AIDS as a new disease in its early stages, and the response to Lyme's disease. When I thought about how to do that, the first source that really came to me was Randy Schultz's book, And the Band Played On. I don't know how many of you have had a chance to read that, but if you're interested in response to a disease, a response to an epidemic in the case of AIDS, it's a fascinating history of how we missed the boat. And because of that, I've really taken a good portion of my remarks, really verbatim from the book. And I do want to give him credit for that, but he's written it far better, I think, than I could have. And as I was looking at these excerpts, again, it fascinated me to see how many clues we missed, how many people who were really heroes in terms of screaming at people that people were going to die if we didn't do something about this disease, and how many people are dying unnecessarily. If we had really
zeroed in on this illness in its early stages, we probably would not have the numbers of people dying of AIDS now. And of course, the numbers of deaths are up above 60,000 at this point in 1988. So, let me just make a few remarks, and then I'll read some things from Randy Schultz's book. AIDS is really a household word at this point. There probably is almost no one who doesn't understand or doesn't know what AIDS is, at least in some form. A lot of people have misconceptions about AIDS, and I'll try and leave some time for questions, so that if you have any specific questions, I'll try to answer those. There's a lot of mystique about AIDS. There's a lot of misconception about AIDS, but the term is familiar, at least I think, to most people at this point in time. 10 years ago, if we had suggested to anyone that every day when you picked up the newspaper, you would be reading about the lifestyle and practices, intimate practices of IV drug users and homosexual men on a daily basis, I think people would have looked at you like you'd sprouted 3 heads. And in fact, that's really what has happened at this point. AIDS is now very commonly in the media, but that wasn't always the case. The prologue of the book starts this way. By October 2nd, 1985, the morning Rock Hudson died, the word was familiar to almost every household in the Western world: AIDS. And Rock Hudson is actually a real landmark in terms of awareness about AIDS. I'm not suggesting that you have some movie star get Lyme's disease, but the fact that Rock Hudson became sick with AIDS really brought AIDS out into the forefront in terms of media. He was a very visible person, and in fact, when I was walking through the offices at GMHC over the summer, they were showing me around, and there are file cabinets upon file cabinets of all the early newspaper clippings and magazine clippings about AIDS, sort of an archives that's really not been cataloged very well yet. Things that were collected by the founders of GMHC, which is was largely a volunteer organization. They stopped at about the time Rock Hudson died, because once Rock Hudson died, you couldn't keep track of what was in the media anymore. Before that, you could, because it was scarce. Acquired immune deficiency syndrome had seemed a comfortably distant threat to most of those who had heard of it before, the misfortune of people who fit into rather distinct classes of outcasts and social pariahs. But suddenly in the summer of 1985, when a movie star was diagnosed with the disease, and the newspapers couldn't stop talking about it, the AIDS epidemic became palpable and the threat loomed everywhere. Suddenly there were children with AIDS who wanted to go to school, laborers with AIDS who wanted to work, and researchers who wanted funding. And there was a threat to the nation's public health that could no longer be ignored. Most significantly, there were the first glimmers of awareness that the future would always contain this strange new word. AIDS would become a part of American culture and indelibly change the course of our lives. The implications would not be fleshed out for another few years, but on that October day in 1985, the first awareness existed just the same. Rock Hudson riveted America's attention upon this deadly new threat for the first time, and his diagnosis became a demarcation that would separate the history of America before AIDS from the history that came after. The timing of this awareness, however, reflected the unalterable tragedy at the heart of the AIDS epidemic. By the time America paid attention to the disease, it was too late to do anything about it. The virus was already pandemic in the nation, having spread to every corner of the North American continent. The tide of death that would later sweep America could perhaps be slowed, but it could not be stopped. The AIDS epidemic, of course, did not arise full-grown from the biological landscape. The problem had been festering throughout the decade. The death tolls of the late 1980s are not startling new developments, but an unfolding of events predicted for many years. There had been a time when much of this suffering could have been prevented, but by 1985 that time had passed. Indeed, on the day the world learned that Rock Hudson was stricken, some 12,000 Americans were already dead or dying of AIDS, and hundreds of thousands more were infected with the virus that caused the disease. The number of people estimated to be infected with the human immunodeficiency virus now is estimated to be somewhere between 1 and 2 million. But few had paid any attention to this. Nobody, it seemed, had cared about them. The bitter truth was that AIDS did not just happen to America, it was allowed to happen by an array of institutions, all of which failed to perform their appropriate tasks to safeguard the public health. This failure of the system leaves a legacy of unnecessary suffering that will haunt the Western world for decades to come. There was no excuse in this country and in this time for the spread of a deadly new epidemic. For this was a time in which the United States boasted the world's most sophisticated medicine and the world's most extensive public health system, geared to eliminate such pestilence from our national life. When the virus appeared, the world's richest nation housed the most lavishly financed scientific research establishments, both inside the vast governmental health bureaucracy and in other institutions, to investigate new diseases and quickly bring them under control. And making sure that government researchers and public health agencies did their jobs were the world's most unfettered and aggressive media, the public's watchdogs. Beyond that, the group most affected by the epidemic, the gay community, had by then built a substantial political infrastructure, particularly in cities where the disease struck first and most virulently. Leaders were in place to monitor the gay community's health and survival interests. And I think there is a good model there for what this organization is trying to do about a different disease. The gay community was not organized around any of these kinds of issues 10 years ago, and now it is extremely well organized around these issues. The gay community is reaching out to people with AIDS who are not gay. Many of the volunteers who work with them are not gay. I'm not a man and I'm not gay either, but I happen to feel very strongly about this issue, and I'm not the only one who volunteers time in that way. So I think there is a model in terms of a real volunteer effort in this area. But from 1980, when the first isolated gay men began falling ill from strange and exotic ailments, nearly 5 years passed before all these institutions, medicine, public health, the federal and private scientific research establishments, the mass media, and the gay community's leadership mobilized the way they should in a time of threat. The story of these first 5 years of AIDS in America is a drama of national failure, played out against the backdrop of needless death. People died while Reagan administration officials, I'm sorry, my politics do come out quickly, and I do agree with this man. People died while Reagan administration officials ignored pleas from government scientists and did not allocate adequate funding for AIDS research until the epidemic had already spread throughout the country. There is a lot of money allocated to AIDS research right now, although the numbers are deceiving. If you look at the budget numbers for AIDS, it includes the money that's used to test prisoners, which the government mandates. It includes a lot of things that are not research dollars. But there is a lot of money now. I think the point of this all is that we needed the money earlier than we got it. And there's a lot of fear that the money will decline again as AIDS becomes more and more a disease of the ghetto. As the numbers go down in the gay community and go up in the IV drug using community, that the monies will again drop. People died while scientists did not at first devote appropriate attention to the epidemic because they perceived little prestige to be gained in studying a homosexual affliction. Even after this denial faded, people died while some scientists, most notably those in the employ of the United States government, competed rather than collaborated in international research efforts, and so diverted attention and energy away from the central struggle against the disease itself. People died while public health authorities and the political leaders who guided them refused to take the tough measures necessary to curb the epidemic's spread, opting for political expediency over the public health. And people died while gay community leaders played politics with the disease, putting political dogma ahead of the preservation of human life. People died and nobody paid attention because the mass media did not like covering stories about homosexuals and was especially skittish about stories that involved gay sexuality. Newspapers and television largely avoided discussion of the disease until the death toll was too high to ignore and the casualties were no longer just the outcasts. Without the media to fulfill its role as public guardian, everyone else was left to deal and not deal with AIDS as they saw fit. In those early years, the federal government viewed AIDS as a budget problem, local public health officials saw it as a political problem, gay leaders considered AIDS a public relations problem, and the news media regarded it as a homosexual problem that wouldn't interest anybody else. Consequently, few confronted AIDS for what it was, a profoundly threatening medical crisis. Fighting against this institutional indifference were a handful of heroes from disparate callings. Isolated teams of scientists and research centers in America and Europe risked their reputations and often their jobs to pioneer early research on AIDS. There were doctors and nurses who went far beyond the call of duty to care for its victims. Some public health officials struggled valiantly to have the epidemic addressed in earnest. A handful of gay leaders withstood vilification to argue forcefully for a sane community response to the epidemic and to lobby for the funds that provided the first breakthroughs in research. And there were many victims of the epidemic who fought rejection, fear, isolation, and their own deadly prognoses to make people understand and to make people care. Because of their efforts, the story of politics, people, and the AIDS epidemic is ultimately a tale of courage, as well as cowardice, compassion as well as bigotry, inspiration as well as banality, and redemption as well as despair. It is a tale that bears telling so that it will never happen again to any people anywhere. I mean, I think it's really there is a lot of analogy in terms of what you're trying to do in awareness to the AIDS epidemic. What I thought I'd do is pull out for you some of the chronology of what happened in the first year that there was any awareness of AIDS. This book starts in 1977. Actually, it starts in 1976 with the tall ships, which I thought was very interesting, and things that were happening socially in New York. Of course, in this country, we weren't really aware of AIDS until Rock Hudson. You know, we weren't really aware of AIDS as an entity very much until 1983, 1985. But it clearly was here before that, probably even long before 1976. The first person they talk about in this book was a physician who worked in Zaire. She was 47 years old when she died. An autopsy revealed that Greta Rask's lungs were filled with millions of organisms known as Pneumocystis carinii. They had caused a rare pneumonia that had slowly suffocated the woman. The diagnosis raised more questions than answers. Nobody died of pneumocystis. Intrigued, a friend of hers wanted to start doing research on this disease, but he was dissuaded by wizened professors who steered him toward work in malaria. Don't study pneumocystis, they told him. It was so rare that there would be no future in it. He'd have a good job today. There, certainly are more cases of pneumocystis than we ever thought we would see. They talk about some of the gay men, some of the early founders of the gay men's health crisis, some of the first patients in San Francisco and in New York. And this is a conversation that occurred in 1980 in Fire Island. After Eno excused himself, Larry, who's Larry Kramer, who was one of the founders of GMHC, thought about how strange it was that summer. All the people seemed to talk about were the latest intestinal parasites going around. Dinner conversation often evolved into guys swapping stories about which medication stopped out the stubborn little creatures and whether Flagyl, the preferred anti-parasite drug, was really carcinogenic. It was like eavesdropping on a bunch of old ladies sharing arthritis stories on shaded benches in Miami. Again, this is 1980. That's sort of a nice comparison, right? Then it's still in 1980 in Copenhagen. Second thoughts, of course, would come much later because even in our advanced times, it is still not uncommon for people to fall sick and even die for unexplained reasons. In any event, the agricultural engineer who had died in Copenhagen was the first to die, passing away that September at a hospital not far from where a surgeon named Greta Rask had succumbed to the same pneumonia a little less than 3 years before. These two deaths in Copenhagen presented their own salient clue to the identity of a killer that quietly stalked 3 continents in 1980. In Europe, the microbe's first victims were largely linked to Africa. Just weeks after this physician was rushed from South Africa to Copenhagen, a 34-year-old airline secretary from Africa took advantage of her employment travel benefits to fly her sickly daughter from Zaire to Belgium. They talk a lot about how people moved around. Any kind of an infectious disease, obviously in a mobile society, is going to just spread a lot faster. In the United States, unexplained maladies from a mysterious new syndrome would be traced back to 1979. They've actually now been traced back farther than that. It was on a balmy September day in 1979 that Rick Welikoff had been sent to Dr. Linda Lobenstein for blood studies. She duly noted the generalized rash that resisted treatment and the enlarged lymph nodes all over his body. Lobenstein surveyed the man and assumed he had lymph cancer. Later, a dermatologist told Linda that the man's rash was a skin cancer called Kaposi's sarcoma, a very rare cancer that was almost never seen in young men. The early stages of the discovery of AIDS was really physicians talking to each other. Gee, I saw one of these patients, and you saw one of these patients, and you saw one of these patients. And had they not had that kind of contact, it might even have taken longer, and it certainly did take longer for anybody to listen to them. Given the rarity of the cancer and the novelty of a case in such a young, non-Mediterranean man, Linda decided to follow Rick closely and mentioned him to several other doctors. She would have to write it up someday. 2 weeks after she first saw the school teacher, she got a phone call from a colleague at the Veterans Administration Hospital 3 blocks south of New York University Medical Center on 1st Avenue. You're not going to believe it, but there's another one down here. and in California as well. Too much is being transmitted here. It was getting to be the standard finale to Dr. Selmer Dritz's rote presentation on the problem of gastrointestinal diseases among gay men. She felt her analysis had particular gravity at this monthly meeting of the sexually transmitted disease experts at the University of California at San Francisco Medical Center. This was one of the most prestigious medical schools in the nation, she knew. These doctors needed to know that something new was unfolding in the bodies of gay men, and they needed to be alert to see where it might lead. This was not how Dr. Dritz, the infectious disease specialist for the San Francisco Department of Public Health, had planned to spend the later years of her career, being one of the nation's foremost authorities on organisms that were setting up residence in the bowels of homosexual men. Her expertise had started soon after 1967, and the book goes on to talk about her role in this. She actually had a blackboard in her office. Then she kept track initially of all, obviously now we could never keep track of these numbers on any kind of a blackboard, but she kept track on a blackboard of the patients that were diagnosed in San Francisco and who their contacts had been. And a lot of that work, she moved from a blackboard eventually to a book. And when she retired, because no one would listen to her, she destroyed all those records. Okay, this talks about St. Luke's Roosevelt. The next morning, Dr. Michael Lang peered into Nick's room at St. Luke's Roosevelt Hospital. This was a gay man. A neurologist had found 3 massive lesions on the young man's brain during a CAT scan. Lang had been called in as an infectious disease specialist. Nick was slumped to one side of the bed. His gray eyes were covered with a milky white film, and the left side of his face seemed to sag. His fever was escalating. Nick had been dying in slow motion for a year, the doctors told Lang, and no one could say why. The sight lingered with Lang for years, long after such deathly visages had become familiar, and Lang became an international authority about such things. Lang would always recall that first moment, staring into the hospital room at Nick, as the event that separated his before and after. Years later, Lang could instantly remember the date, the way he could recall the anniversary of his marriage or his kids' birthdays. It was November 1st, 1980, the beginning of a month in which single frames of tragedy in this and that corner of the world would begin to flicker fast enough to reveal the movement of something new and horrible slowly rising from the Earth's biological landscape. And, you know, when you think back to 1980, it's amazing because it took a long time after that for people to really pay attention. It was the end of 1980, a year when the top movies were Coal Miner's Daughter and the second Star Wars fantasy, The Empire Strikes Back. Later surveys would show that in the United States, 55 young men had been diagnosed with some infection linked to the new virus by the end of 1980. 10 others had been diagnosed in Europe, while many more were ailing among the uncounted sick of primitive Africa. Slowly and almost imperceptibly, the killer was awakening. So the numbers were 55 in 1980. As I said, now we've had 60,000 people die, and far more than that diagnosed. But these numbers escalated very rapidly. Talking about the government really had a slow awakening. It's still waking up, I think, to some extent to this crisis. The National Institutes of Health did not fare too poorly under the Reagan proposals. This was the new Reagan budgets, losing only $127 million of Carter's proposed $3.85 billion. Tim Westmoreland sighed, however, when he saw the Reagan plan for the Centers for Disease Control. The Executive Office of Management and Budget, or OMB, wanted to cut the Carter budget's recommended $327 million in CDC funding to $161 million. None of this was particularly surprising. President Reagan had gone into office promising that federal programs would be turned over to the states. About half the money cut from the CDC budget would go to the states in block grants so that they could administer comparable programs locally. Westmoreland, however, worried that the slashing of the CDC budget courted disaster. The CDC was the front line in any public health emergency that might befall the country. In the past decade, it had been called upon to tackle Legionnaire's disease and toxic shock syndrome, diseases that affected far fewer people than AIDS affected. These weren't pork barrel special interest programs or social engineering schemes by pointy-headed liberals. The CDC usually got involved when people were dying. And the CDC was really very instrumental in the early epidemiology, but it was not the CDC so much as people working within the CDC who squeaked money out of other budgets, who put in a lot of their own time because the money simply wasn't there to support adequate epidemiology on AIDS. And it goes on to describe a little bit of that, but I don't think we need to spend too much time on that. On Friday, June 5th, 1981, the Centers for Disease Control Morbidity and Mortality Weekly Report published what would be the first report on the epidemic, based on the Los Angeles cases of pneumocystis. In the week before publication, skittish CDC staffers debated how to handle the gay aspect of the report. And at this point, virtually all of the people who had been afflicted with AIDS were gay men. Some of the workers in the venereal disease division had long experience working with the gay community and worried about offending the sensitivities of a group with whom they could clearly be working closely in the coming months. Just as significantly, they also knew that gays were not the most beloved minority in the world, in or out of the medical world, and they feared that tagging the outbreak too prominently as a gay epidemic might fuel prejudice. As it was, the fact that the hepatitis vaccine project had been largely a homosexual effort was downplayed for both Congress and the administration for fear that it would squash the program. The report, therefore, appeared not on page 1 of the report, but in a more inconspicuous slot on page 2. Any reference to homosexuality was dropped from the title, and the headline simply read, Pneumocystis pneumonia, Los Angeles. Don't offend the gays and don't inflame the homophobes. These were the twin horns on which the handling of this epidemic would be torn from the first days of the epidemic. Inspired by the best intentions, such arguments paved the road toward the destination good intentions inevitably lead. It was really a very strong political struggle. I mean, this was very well documented information, but it didn't appear in prominent places because people didn't want to offend the public or offend the gay community, and I think they have to take some blame for that. They talk about retroviral research as well. That was something that people thought, well, you know, retroviral research is nice, but we don't really have to worry much about retroviruses. We didn't really have to worry much about infectious diseases. We had really operated in this society for a long time as if we didn't have any infectious diseases to fear, and so people were reluctant to put money into that kind of work. The first official report on the outbreak of Kaposi sarcoma was released in the Morbidity and Mortality Weekly Report of July 4th, 1981, 5 years to the day after the tall ships. The title of the report was Kaposi Sarcoma and Pneumocystis Pneumonia Among Homosexual Men, New York City and California. In the driest possible prose, the report outlined the common symptoms of the KS patients. So again, this is a long time before we were willing to admit what the numbers were going to be. In the next couple of sites I have talk a little bit about those numbers. By early August, and this was August of 1981, there were 18 cases of gay men suffering from the baffling immune deficiency in the San Francisco Bay Area. 2 had died. No one yet knows the extent of this potential danger, but playing it on the safe side for a few weeks cannot hurt. The Sentinel, a local gay paper, editorialized. Certainly been much longer than a few weeks. Just a few short years ago, the government dropped millions of dollars into research to determine the cause of Legionnaire's disease, which affected relatively few people. No such outpouring of funds has yet been forthcoming to research the hows and whys of Kaposi sarcoma, a rapidly fatal form of cancer that has claimed far more victims in a very short time than did Legionnaire's disease. Then another side about the Center for Disease Control. The Center for Disease Control, as I said, has really been instrumental in putting together the pieces on AIDS. I think that they're to be commended for that. I think, if anything, their definitions are very strict, and probably the numbers are far more than we usually document, because their definition of what constitutes AIDS is quite restrictive. On the day that Ken Horn's body was cremated, this is December 1st, 1981, Jim Curran dictated a memo to the CDC director. Curran was politically savvy enough to know that this was not a good time to be asking for more money, what with the axe falling on health budgets throughout the country. And that process, of course, has continued over the past 7 years. But he was also convinced that the new epidemic presented the potential of a serious health threat if it wasn't tackled. Everybody in the Kaposi Sarcoma and Opportunistic Infections Task Force had figured that by now reporters would be crawling all over this story. Legionnaire's disease and toxic shock syndrome had, by this stage in their respective epidemics, warranted almost daily front-page treatment, which in turn engendered the interest of members of Congress, who tickled loose more money for research. Yet newspapers and television broadcasts rarely mentioned a word about the new epidemic. Instead, budgetary warfare had to be waged through discreet internal memos. In November, minutes of the task force meeting forwarded to CDC brass mentioned that the meetings repeatedly shifted, as one memo put it, to discussion of the impact of budget cuts on its own function and attempts to find ways to minimize disruption of the investigation if special funds were not forthcoming. Now Jim Curran had finished his modest 6-month budget proposal of $833,800 for the task force's next year of work. His boss had promised to argue for the supplemental funding, which represented only a fraction of a percent of the Public Health Service budget. Curran waited eagerly for a reply to his request, and he waited and he waited. And that was typical of all of the people. I mean, it's really a phenomenal study in terms of people putting pieces together, identifying what was happening with the disease, and no one listening to them. Isolated researchers, and the virus has really been discovered, and a lot more is known about it in a shorter period of time than almost any other disease that one could think of. But it took a whole lot of badgering by people. And one of the things that happened, of course, early in the epidemic, although not as early as we'd like to think about, was that it became not a gay disease. Initially, most of the victims of AIDS, and I use that word hesitantly because it's a word that people with AIDS object to very vehemently, and I think people with most diseases don't like to be called victims. But the initial people who were afflicted with AIDS were gay men. It became obvious, though, relatively quickly that it wasn't just gay men. It's just that no one wanted to listen. There was a very astute pediatrician in the Bronx who cared for primarily minority children who came from poor families and who came particularly from a community that had a high incidence of drug abuse. And he very quickly diagnosed the fact that he was seeing immune deficiency in babies, but no one would listen to him. In December, Dr. Rubenstein wrote up an abstract to present at a conference of the American Academy of Pediatrics. In his opinion, the evidence was becoming overwhelming. He had 5 black infants who had been thoroughly worked up. Some had pneumocystis pneumonia. They all had the same T-cell patterns common to gay pneumonia victims. At least 3 of the kids were the children of promiscuous drug users. The implications were clear to Rubenstein, and they needed to be shouted from the rooftops. The fact that children contracted the disease indicated that it was not from poppers or anything particular to the homosexual lifestyle, but that it was the effect of a new virus that mothers were transmitting to their children, probably through the placenta. Society needed to be steeled not only for a new infectious disease among gay men, but also among drug addicts who could spread it to their children. Such thinking, however, was simply too far-fetched for a scientific community that, when it thought about gay cancer and gay pneumonia at all, was quite happy to keep the problems just that, gay. The Academy told Rubenstein he could not present his paper at the conference, and among immunologists, word quietly circulated that the Israeli researcher had gone a little batty. He continued his fight, however, and did ultimately convince people that AIDS was a disease in children as well. Let me just give you a little bit more, and then I'm going to stop and see if you have any questions. On March 19, 1982, the Centers for Disease Control reported 285 cases of gay-related immune deficiency in 17 states. Half the cases were diagnosed in New York City, and about a quarter of the cases lived in California. 5 other nations, all in Europe, also reported cases of the disease. Quickly, the disease had spread. Now we see 285 cases, and about half of those had probably died because the mortality was at about 50% for most of those years. And it escalated and it escalated and it escalated to the point where the numbers were doubling every 6 months. And as I said, we've now lost 60,000 people to AIDS. I think, that gives you the sense of what I think are the most compelling things about trying to make the public recognize a new disease, a threatening disease. Unless the public recognizes it, you don't get any kind of lobbying for any money. Unless the government is willing to think about it, you don't get any money. And the media, the lack of media attention to this disease, and then the refusal to recognize it as anything more than a gay disease, really contributed dramatically to the numbers early on. And then later, of course, we've now had a surge of things in the literature about AIDS being heterosexually transmitted. There has always been evidence that there was a small percentage of people with AIDS had gotten it from heterosexual transmission. But the failure to recognize that hampered educational efforts. It did a lot of damage. And I think it's important to think about how the media has an impact on what we do for a new disease. It's important to recognize, I think, as I said before, in AIDS in particular, the work of some very significant individuals, people who just fought because they believed in what they were fighting for, whether they were gay men who happened to have the disease, whether they were physicians or researchers who felt that they were seeing the tip of a horrible iceberg. People fought as individuals to try and get some visibility for this disease. We were talking about GMHC before I came up here. I was talking to Karen, and one of the things that's striking about their archives, the archives were kept by people who started the organization, and this kind of volunteer effort had not been really known previously in the gay community. Unfortunately, at this point, most of the founders of GMHC are dead. Now, it's not been around for that long, but in a very short period of time, many of the people who were involved in those early efforts are dead. And I think it's important that we keep up the struggle and try and figure out what's going on with this. Let me take some questions because I know it's almost time for the next person. Does anybody have any questions? Yeah. It's still the official definition that's used. It's been updated. Initially, it was a very strict definition, the CDC definition of AIDS, based on the initial cases that were seen, pneumocystis pneumonia, Kaposi sarcoma. Children don't get those kinds of opportunistic infections. They get different infections. So ultimately, they had to change it to reflect what happens in children. Women probably get different infections than men get, but so far that hasn't popped into the definition. Women, I think, are grossly underdiagnosed with AIDS. Because people don't expect to see AIDS in women. If I walked into a doctor's office with pneumonia, they would probably think it was pneumonia. If somebody my age was male and unmarried, particularly, walked into a doctor's office, they'd probably just assume that the guy had AIDS. I think there's underdiagnosis in women. There was underdiagnosis in children also because of the infections appearing differently. What happened was, obviously, we got to know more about the disease, and we saw that some people didn't get Kaposi sarcoma and pneumocystis. Some people just got massive wasting or dementia. And so the definition has since been changed. But the numbers that you read, the numbers that I read to you, the numbers that you read in the paper, are probably grossly underestimated. There are probably a lot of people dying in shelters of tuberculosis who have AIDS. Babies who are dying of strange infections who have AIDS. Because the definition is restrictive, it does affect the impact, I think, of the numbers. Any other questions? Yeah. Oh, it's far greater than that. It's nobody really knows because you can't get in and study epidemiologically what's happening in Africa the same way that you can here, and there are obviously very different countries involved. But in some of the countries of Africa, the incidence of AIDS is overwhelming. The other thing that's and many people have died. Far more than 60,000. I can't give you numbers, but people estimate millions and millions more to be infected. The other thing that's strikingly different about Africa is that it seems to be as easily transmitted heterosexually as it is homosexually, male to female and female to male, and that has not been the picture that we've seen in this country. But in Africa, there is just as high an incidence of AIDS in women as there is in men. And it raises a lot of issues in terms of women having babies and the incidence of AIDS in those babies. In third world countries where we've promoted breastfeeding because of poor sanitation, AIDS is transmitted through breast milk. And it raises a lot of ethical issues on a social level. But the numbers are far greater than they are here. Yeah. there's probably some people who'd like to do that, but I don't know if they know quite how to do it. I mean, a lot of the people in Africa don't travel, but of course there are a lot of people who do travel, and there are a lot of people who travel to Africa. There were some, every once in a while you'll read a story in the paper. There are different strains, it's thought now, of the AIDS virus, or different strains of the type of virus that the human immunodeficiency virus is. And there was one new strain that popped up in somebody who was trying to get into one of the airports in New Jersey, and they wanted to keep the person out. I think we have to remember how AIDS is transmitted. AIDS is transmitted primarily through the sharing of blood and body fluids, whether it's through sexual practices or through the sharing of needles. Although it is also transmitted perinatally. I don't know what efforts one can make. I think there's an awareness that this is an overwhelming problem in Africa, but I don't think we've figured out how to keep it from getting here. Clearly we didn't do that to start with. Anybody else? No? Thank you.
Well, we're all aware that throughout the course of Lyme disease in any stage, there have been treatment failures and successes. But more frequently, pardon? Sure. Okay.
I was going to do this later today, but I thought it would be appropriate now after Kathleen had talked. She had mentioned when AIDS had started and who the people were, and they're no longer around. As you all know, there was somebody in particular that was around at the beginning of Lyme disease recognition in the United States. She's never been formally recognized. She's never been formally thanked for the efforts that she's undertaken. Polly Murray is the mom in Lyme, Connecticut in 1975 who said, "I think there's something wrong," and called attention. That's the year she finally got attention. She had started in 65, and she had fought alone and then found some other people to listen. She had called, she had become what might have been considered by some people a nuisance, and she continued valiantly by herself, slowly gathering a couple of people. Then she got some more interested. Finally, the news broke, and they called it for a while Polly Murray's disease, or they call it Lyme disease. She's the one who gathered the information and statistics and gave it to Dr. Steer so that he could start investigating a disease that finally had a name commonly used in the United States as Lyme disease. We would like to award her an official certificate, a plaque, to thank her publicly for what she's done for countless people across the United States. Would you like to come up? Honors Polly Murray for outstanding personal excellence in being the mom who fought for those suffering from a disease with no name. And we all thank her.
Congratulations, Paul. All over it. As I was saying, we heard of all types of treatment failures and successes at all stages of Lyme disease, but most particularly in the later phases when the organism is particularly invasive in the tissues. We've also heard about repeated attempts at controlling the disease on a short course for assessments and failures along those lines. The next speaker has taken a somewhat different approach and in treating difficult cases of late Lyme disease. Dr. Paul Lavoie, rheumatologist, has been working on this for several years. He's from Pacific Presbyterian Medical Center.
Thank you, Ed. And thank you, Karen, and the board for inviting me. It's a pleasure being here. And I, too, was very touched by the plaque that you gave Polly. If anybody deserved recognition, it's Polly. What I'm going to offer today are two problems and a couple of sets of concepts. These are concepts based upon my understanding of the literature, my observations of my own patients. They're very personal. They are very much still in development. They're not answers. And I want you to regard what I'm about to say as that. I'm sure some of the things I'm going to say are a touch controversial. The first problem, frequent therapeutic failures and relapses with current short-term antibiotic therapies. Now we're going to go through just a few literature citations to give you a sense of how this has been alluded to. Alan Steer and others sort of warned us back in 1985 that this was a problem when they saw only a 55% response to 2 weeks of IV penicillin in patients who, by the way, had failed other forms of antibiotic therapy for their chronic arthritis. So already in 1985, it was recognized that 45% of patients were failing or relapsing in the short run. This is a paper that addresses a case of severe meningoencephalitis that failed a couple of different therapies and finally had to be given chloramphenicol. But as you can see, there were a number of therapeutic interventions here. This is a more important paper because we typically we typically think of treating patients who present with the earliest stage of the disease, the ECM stage, as being the stage that's the most easy to turn around. And I think all of us have seen this problem. Basically what it was 5 patients who clearly had early disease were treated in a conventional manner and all went on to develop late disease with arthritis and cranial nerve palsies, peripheral neuropathy, and chronic fatigue and mental dysfunction. This is a more recent paper from this April that Paul DeRay was very much involved in. A 67-year-old woman who develops a multi-system disorder after spending a weekend on the Maryland shore. Dry cough, fever, anorexia, swollen hands followed. Rocky Mountain spotted fever is suspected. She was treated thusly, but was not benefited. And then they happened to notice that her Borrelia burgdorferi antibody titer was very high. So they then treated her with penicillin by vein for 10 days with only transient benefit. She was readmitted looking for all the world like she had dermatomyositis, one of the more raging inflammatory disorders. Again treated with IV penicillin and prednisone. This went on to, she went on to develop the adult respiratory distress syndrome, the ARDS, which is a terrible inflammatory disease of the lungs. And she died after 25 days of the second hospitalization. This woman had received greater than a month of antibiotics. Yet at autopsy, Paul DeRay found Borrelia burgdorferi by silver stain in her lymph nodes. Now I'm going to present a case that I was involved with, and this is truly bringing coals to Newcastle in that this woman lives close by to here. She chose to come out and tell me her story. And I first saw her in December 1987. She was a resident of Westchester County, and her complaint was persistent symmetrical sciatica, that is pain running down the back of both legs on a non-mechanical basis, emotional irritability, mood swings, and poor concentration. Her story went back to May 1986 when she had an expanding annule with a deer tick at the center. Mind you, she lives in a very wooded property, and there are deer on her property regularly. This was soon followed by headaches, nausea, lightheadedness, imbalance, and the symmetrical sciatica. The diagnosis of Lyme borreliosis was assigned by her internist in view of the ECM. He also found a Borrelia titer of 1:64, and he treated her with doxycycline for 10 days with benefit. There was some residual imbalance, nausea, and mild symmetrical sciatica. A little later, there we go. Anyway, a month later or so, 2 months, she developed fulminant diarrhea with nausea and headache. Now, we usually don't think of the gastrointestinal tract as being affected by this disorder, but I personally think that it is, in that I've had a number of cases where the GI tract was involved. At any rate, she had this mnemonic pattern, that is, this repetitive pattern of at least diarrhea, nausea, and headaches, again treated in a conventional way with benefit. Fatigue and the sciatica persisted. 6 months later, she develops poison ivy. Who gets poison ivy in Westchester County in the middle of December? At any rate, she did. She was treated with prednisone for a short course with benefit. A few days later, she noted the recurrence of diarrhea, nausea, and headaches, and again received tetracycline with benefit. She had a similar flare a couple of months later, again benefited. The following month, the symptoms persisted, once again treated. The month after that, another flare, another 10 days of therapy. Later in that month, another flare, another 16 days of therapy. The following month, another flare, treated with erythromycin without benefit, tried on tetracycline again, had a rash, switched to penicillin with some benefit, flared for 36 hours after stopping the penicillin. At any rate, all of these antibiotics and her symptoms persisted. That's when she went to Stony Brook. And she was admitted. The lumbar puncture was normal. They did the T-cell stimulating assay and found it to be negative. But in spite of that negative study, they treated her with IV ceftriaxone for 14 days, and she was much improved, although she still had some sciatica. 2 months later, she's readmitted to the same hospital with similar symptoms. She again had a poison ivy rash, may have been real this time. Treated again with ceftriaxone with benefit. Similar flare, a couple of months later, again ceftriaxone. When I saw her in December 1987, she had full range of motion of her low back. There was no evidence for a mechanical dysfunction. As you can imagine, that had been well attended to. There was mild soft tissue thickening about the knees. The main thing about her appearance was she was awfully anxious. She did have hyperreactivity of her deep tendon reflexes, and in my commercial laboratory I found a Borrelia IFA of 1 to 128. In summary, this is a Westchester County matron with an embedded deer tick, ECM, Lyme IFA, low seropositivity, physician diagnosis of Lyme borreliosis with relapsing constitutional, neurologic, and GI symptoms, responsive to typical short courses of antibiotics, but relapsing following cessation of each course. She received a total of 8 courses of oral and 3 courses of IV antibiotics in 18 months, yet the illness persists. Now, what I'm going to talk about, as the headline said, is the notion of prolonged antibiotics. And here are the premises that I'm operating from. All of our antibiotics today function in this manner. They're effective only during microbial reproduction. Microbial killing follows an exponential decay rule. That is, you kill far more microbes on day 1 than you do on day 5 or on day 100. The therapeutic duration is necessarily a function of the microbial generational time. That is the natural rate that is probably programmed by the microbe's genome from the standpoint of one generation following the other. Here's an example. Staph aureus reproduces in vitro every 19 minutes. We typically treat a seriously affected Staph aureus patient for 2 weeks with antibiotics. Tuberculosis requires 20 hours to reproduce in vitro, and the typical duration of therapy is somewhere from 1 to 2 years. Now, for some reason that slide isn't going in. Let me try again. Well, forget it. All it is, here. We'll skip that slide. It was simply a graphical representation of what I just showed. We're going to compare Borrelia burgdorferi to Staph aureus. Now, on the left-hand side of the slide, the numerator, 0.33, represents the 19 minutes. That is, it's approximately 1/3 of an hour reproduction rate. And 2 weeks, the denominator. On the right-hand side of the equation is the 12-hour reproduction rate of Borrelia burgdorferi, as shown by Alan Barber and presented at the very first meeting on this subject at Yale in 1983. When you calculate it out X in a linear fashion, we're talking about 80 weeks of therapy, not 2. Now, going back to the literature, you find some interesting things. And Dr. Wasserman, back in 1934, wrote, to treat, to treat only to the elimination of symptoms in syphilis will not achieve cure. To cure, we must treat for 18 to 24 months. Now, obviously, no one ever paid any attention to what Dr. Wasserman had to say. This was the reason I ran across this. I don't usually read the archives of syphilology in 1934, but in Sexually Transmitted Diseases, the October-December issue of 1986, that was dedicated to Jim Miller, the great syphilologist from UCLA, I ran across this quote, and I thought it was truly timely. All right, here's the second problem. This one is a little more difficult than the first problem, in my mind. Symptomatic flares while on prolonged antibiotic treatment, and typical cessation of flare if the antibiotics are held. Now, here are some considerations. I feel that this finding is compatible with the known immunopathogenesis of Lyme borreliosis, and that the occasional elevation of serotypes following flares and or prolonged therapy is also consistent with these immunologic mechanisms. Here is Lavoie's very simple notion, immunologic notion, of how the immunology of borreliosis occurs in late disease. I'll just speak up here. What I'm representing here are spirochetes sitting in a very indolent manner in the parenchyma. You pick the organ, that's pretty much how they sit. They don't seem to cause much harm in the tissues where they sit. On the left is a representation of a blood vessel. Within the blood vessel is where most of our immune active cells sit most of the time. The bottom one is the macrophage, the great scavenger. Then there's the T helper cell, and there's a B cell with a little bit of globulin directed against this spirochete sitting there. Now we come along and we treat. And this is what I think happens. We obviously start to deplete the number of organisms in the parenchyma. The macrophage picks up the antigen, tells the T helper cell that we have an invader here. Obviously the macrophage is blind, doesn't realize it's dead. The T helper cell in turn has the B cell go to work and make globulins. And these globulins attach to the dead antigen that is circulating. turn, we have the formation of immune complexes, which fortunately have a relatively short-lived lifespan, but I think do occur in the course of our antibiotic therapy. And my apologies to Ed and the group at the State Health Lab in New York when I've oversimplified and misstated certain concepts. This is a case that I think could illustrate this to some degree. It illustrates a number of points. We'll just go through it. This is a 28-year-old white woman who came from very far northern California, a very, very wooded rural area by Mount Shasta. She had pars planitis. Pars planitis is a cotton wool kind of exudative disorder of the periphery of the retina, seen in multiple sclerosis. There was associated macular edema and microaneurysms of the retina. She'd had progressive visual impairment. Now, this is a woman that previously had not required the wearing of any glasses. Her vision was 20/50 in the right eye and 20/70 in the left eye. Keep those numbers in mind. A Marcus gun pupil, that is a pupil that would change its diameter very rapidly for no apparent cause, was going on while the other pupil remained normal. And on a magnetic resonant image of her brain, she had multiple white matter foci, high reflectance foci, that very much substantiated the notion that this was MS. But the ophthalmologist couldn't tell that she had MS otherwise, so she sent the patient on to the neurologist. The neurologist says, well, this lady may have eye findings of MS, but she doesn't have MS otherwise. And because he recalled the fact that we were seeing these white matter bright foci on MRI, he had her tested in my laboratory. That's all I saw of her. In fact, I didn't see her. We just had her tested. And her test was negative. So eventually she insisted on being seen. So I did get to see her, and that was in September of '87. Her history also included cardiac ectopy and palpitations since the age of 21. Migratory dysesthesias, that is, pins and needle sensations in different parts of the body for no good reason. Variable pains of joints, especially the knees, since 1980. Chronic fatigue for 4 months. Low-grade fevers for 5 weeks. Intermittent galactorrhea since 1983. Galactorrhea meaning discharge from the breast, a milky discharge. Urinary bladder spasms for 2 years. Chronic anxiety, and she'd of course had multiple tick bites through her early years in Sonoma County and had been re-exposed up there in Shasta County. My examination didn't show very much. She was slender, she was anxious, and she had absent ankle reflexes. That by itself is a little reminiscent of Tabes, and in a 28-year-old shouldn't be happening. Her laboratory studies were non-diagnostic, and I ran the usual broad screening panel. Her FTA-ABS was negative, as was her Borrelia IFA in the very same commercial laboratory. Doxycycline was started, however, since I felt that there was very little to be lost. She came back the next month, and she claimed a little improvement in her vision. She was still having the Marcus gun pupil. The macular edema had decreased according to the ophthalmologist, but she was having new panic attacks. A month and a half later, she had some more headaches. She had developed some lightheadedness. Her left knee had been especially painful. The dysesthesias had cleared, and the galactorrhea had cleared. And as you can see, her visual acuity had already improved. Now 20/40 in the right eye and 20/50 in the left eye. It was 20/70 in the left eye before. In February of '88, the lightheadedness continued. The Marcus gun activity had stopped. The visual acuity had again improved some more. The ophthalmology examination had improved. And on the, I think this was the third IFA done in the very same laboratory, she was now positive at a dilution of 1:64. The next month, her joint pains had cleared. She no longer needed glasses to read. And by June, she was virtually asymptomatic not having panic attacks, had normal vision in the right eye, and much improved vision in the left eye. And the macula on examination was normal. So in summary, this is a young woman with progressive visual loss attributable to multiple sclerosis-like retinal findings and with cranial MRI abnormalities also consistent with MS. She experienced measurable improvement of visual acuity, flares of other symptoms, and Borrelia-Burgdorferi seroconversion while on prolonged doxycycline therapy. In conclusion, I'd like to leave you with these thoughts. Current short-term antibiotic therapies are frequently inadequate. It is quite possible that these short-term therapies are never curative. Prolonged antibiotic therapy offers a current alternative. Prolonged therapy appears safe, but has its problems. This may be due to immunostimulation. Other therapeutic modalities need to be considered and developed. A safe method of in vivo antisepsis is needed. That is, a therapeutic approach that doesn't depend upon the microbe's reproduction rate, that can kill the microbe through stopping its respiration. And finally, much greater understanding of Borrelia biology within the human host is necessary. Thank you very much. Yes, ma'am.
And I mean, there's no way, is there any way to judge when you cure them, when you should stop, how long to stay on it? I mean, you just treat them for 6 months and...
Well, I started out with this, I picked a year because I was quite convinced that anything less than a year would not work with traditional antibiotics. And the conviction came about from having watched people go through a couple of months, 4 months, 6 months, 9 months, and having failed, that is, relapsed. And after a year, I started to stop my patients. And then I started to see relapses after a year. So I decided a year isn't long enough. Now I'm telling my patients, well, we've got to talk about 2 years. And I don't like to say this. I just don't like to have to feed folks antibiotics for that long, especially when they're really pretty well in the main. But right now, I don't know that I have much of an alternative. With respect to the troubles from this, I don't think the troubles are very great. Fortunately, with the cyclines, we have a long experience in the dermatologic field, where dermatologists have treated acne vulgaris for very prolonged periods of time with the cyclines and haven't run into much other than minor problems. And basically, that's what I'm seeing with the standard oral antibiotics over prolonged therapy. I was very worried in the beginning that I would be causing changes in the natural flora that would allow people to become superinfected. I have not seen one such case. So I think that that is a theoretical worry and not truly a practical worry. From the standpoint, I'll be with you in a moment, sir. From the standpoint of other experiences, we don't hesitate to use multiple, far more hazardous antibiotics in the treatment of TB for 1 to 2 years. We certainly don't hesitate to use very, very hazardous antibiotics for the treatment of leprosy forever. I was just reading an article on the treatment of Wegener's granulomatosis with Bactrim, or with trimethoprim sulfa. And you know, in that group of patients, until the antibiotic value was discovered here recently, they were being treated indefinitely with Cytoxan. So who's to care if we treat that kind of a patient forever with trimethoprim sulfa? We need a better armamentarium, obviously, but with what we have today, I think we have to be willing to hang in there. That's my point of view. Yes, sir. Yes. As good as ceftriaxone is, and it is a wonderful agent from the standpoint of its simplicity of administration, QD, and its great ability to penetrate blood-brain barrier, it's still only 2 weeks of antibiotic therapy. It just takes the top off of that exponential curve. Ed, you're going to have to help me. There's a lot of questions from the standpoint of selecting and cutting it off, okay? You pick the one, please. You're not the only one that has the sense. And the sense that I have is that patients with low titers tend to have worse disease. Not only is it harder to diagnose them in the first place, it's really harder to take care of them. There seems to be an inversion. It's as if the high titer is somewhat protective. Thank you, Ed.
The next speaker, Julie Rawlings from the Texas State Department of Health, is actually going to be considering two topics, or actually two presentations. The first of these will consider the seronegative Lyme patient, and the second will consider the Lyme disease mimicking MS.
As you can see by this slide, we isolated spirochetes from 14 patients, 2 from blood, 8 from skin, and then autopsy tissue, spinal fluid, bone, and joint fluid. And what I'd like to do today is to briefly describe the symptoms of 11 of these patients, and you'll probably notice that 50% of those never did develop any kind of antibody. I'd also like to apologize in advance for the spelling errors. I'm not a very good typist, and I'm an even worse proofreader. This slide does show where we got our antibody titers and where we did not. The first patient, except for her vesicular lesions, just presented with a flu-like illness. Her skin lesions did start as just vesicular lesions that were thought to be either fire ant bites or perhaps a spider bite. She picked at the lesions and they did ulcerate. One physician even thought that perhaps she had a snake bite. Her titer, her IFA titer was less than 1 to 64. This is the second patient. He's a 22-year-old male, and he presented to the physician after 4 weeks of multiple erythematous macules on his right thigh, buttocks, and left arm. These macules were approximately the size of a nickel. The physician did do serologies. His RPR titer was non-reactive, and his Lyme disease titer was less than 1 to 64. He was treated with oral tetracycline. The rash disappeared and returned 2 weeks later. These lesions were biopsied, and we did grow spirochetes. He was treated with a second course of antibiotics and gradually improved. His IFA titer remained negative. This is a 55-year-old female. She had been experiencing rashes for approximately a year. 1 month prior to presenting with to the physician, she had a dime-sized scaly lesion with no central clearing. When she was diagnosed as having Lyme disease, she had an erythematous maculopapule on the left forearm and nose. These were biopsied. We did grow spirochetes. Again, her IFA titer was less than 1 to 64. Her other symptoms included 2 months of a sharp radiating pain in her left hip, mild fatigue, and forgetfulness. She was treated with oral tetracycline. 5 months later, she again experienced recurrent left hip pain, bilateral shoulder pain, and another EM-like rash. She was retreated with oral doxycycline. Next patient was one of our state veterinarians who was very enthusiastic about investigating possible cases of Lyme disease. During one of these investigations, he got a flea bite and shortly thereafter began experiencing flu-like symptoms. This is the picture of the flea bite. We did not isolate spirochetes from the bite, but he did submit his blood, and we did isolate spirochetes from his blood. His IFA titer was less than 1 to 64 and remained negative for the next 2 years. He treated himself basically with several courses of oral tetracycline, but he was still experiencing headaches, stiff neck, mental confusion, and arthralgias. He was finally treated with, what's the next patient? Finally treated with IV penicillin and did well for about a year, but since then is retired and now is beginning to experience some symptoms again. This particular man did have a bite. They did not know what it was. They attributed it to possibly a spider bite. He experienced fever and headaches. Then he began having hallucinations. There was confusion. He began having seizures, and he died. Now, he lived in a wooded area in central Texas, 15 acres of land. He lived on a school bus that really hadn't been converted for living. He just slept in a sleeping bag. There were no screens on the windows. It was just open to any kind of arthropod that might want to come in. The area was heavily infested with ticks. The previous year, his 7-year-old son had been diagnosed as having Rocky Mountain spotted fever. There was also a history of alcohol and drug abuse. The patient used cocaine and speed for several years. His girlfriend also reported that that he possibly had been bisexual. We did isolate spirochetes from several of the autopsy tissues. We also found Candida albicans in his lungs. His IFA titer was less than 1 to 64. Unfortunately, the physicians asked for the serum specimen, and we gave it back to them without splitting it, and we were never able to retrieve it to do an HIV titer. We did go out to the land. We did drag for ticks, and we did do some animal trapping. We got rabbits and possums. We did isolate from the possum tissues, and we did isolate from Ixodes scapularis and Amblyomma americanum tick species. This patient is a 35-year-old white male. He also had a long history of rashes. They were described as poison ivy-like and had lasted for several years. He had shown transient improvement with corticosteroids and oral prednisone. When he presented to the physician, he had erythematous raised macules over his chest, neck, and wrists. These may be a little difficult to see, but these are photos taken in the physician's office. They're on his wrist. Biopsies of these lesions did result in the culturing of spirochetes. He did have an IFA titer of 1 to 64. He was given oral tetracycline, seen by the physician, and did show gradual improvement. He did have transient flare-ups during exposure to extreme heat. He again experienced residual rash over the left side of his neck and both wrists 56 days after oral tetracycline. He was retreated with 25 days of tetracycline or doxycycline and subsequently did very well. This patient does not recall any arthropod bite, but did say that his dog was infested with fleas. This patient is a 32-year-old female. At diagnosis, she had headache, stiff neck, generalized myalgias, aching and numbness of the right arm, numbness of the right side of the face, persistent anxiety, and a lesion on her right thigh. This is a picture of that lesion. We did isolate spirochetes. Her IFA titer was 1 to 64. She was treated with oral penicillin, and again, there was either a treatment failure or something. She was retreated and had gradual improvement. 5 months later, she was still asymptomatic. Again, this patient does not remember a tick bite. She talked about having a problem with fleas in her home. This patient is a 32-year-old white male. Again, had been experiencing rashes, pruritic ulcerating lesions on both elbows. This is a picture taken in the doctor's office. These were biopsied and cultured for spirochetes. His IFA titer was 1 to 128. He was treated with oral tetracycline, began experiencing symptoms, was retreated with intramuscular penicillin, and subsequently did very well. This is a 6-year-old boy who experienced 1 month, this is his mother's description, 1 month of a bright red rash followed by peeling of the skin and then several episodes of the vesicular rash. The physician saw him when he presented with the vesicular rash. This is not a picture of his particular lesions, but this is when the mother was shown photographs. This is the photograph she picked out as being most like her son's rash. We asked the physician to submit vesicular fluid from the center of these lesions, and we did isolate spirochetes. His IFA titer was 1 to 256. We looked at the serologies on his family because his father had also become ill following several sessions of National Guard duty. The training was in an area that was where there was a terrible tick problem, and what he would do is store his gear in the garage without unpacking it, and the family pets went in and out of the house through the garage. As you can see, several members of the family also had antibody. We also did serologies on the pets. The cat that had the highest titer was strictly an inside cat. His dog never did, or their dog never did develop antibodies. This is a 67-year-old female. She had been having symptoms for quite a while, back pain, right arm weakness, dizziness, forgetfulness, and a recent pruritic ring-shaped lesion that began as a mosquito bite, or what she described as a mosquito bite. The physician did biopsy this lesion, and we were able to isolate spirochetes. Her IFA titer was 1 to 256. She was treated and seemed to do well on oral doxycycline. This is a 79-year-old female. Again, had been experiencing symptoms for quite a while: weakness, fatigue, and severe left knee pain. 16 days prior to being admitted to the hospital, she again was experiencing recurrent knee pain, and they did an IFA titer. Her titer was 1 to 512. 4 days before being admitted to the hospital, she did have an EM-like lesion on her back and abdomen. She was experiencing hallucinations. They did draw joint fluid and submitted it to us for isolation. We did detect spirochetes in this joint fluid. She was admitted to the hospital with increased left knee pain, decreased hearing, confusion, lethargy, and slurred speech. She was given IV penicillin and seemed to improve. Are there any questions about this part of the presentation before I go on to the next part? Yes?